All right, thank you. We can get started with the luncheon that's sponsored by TREO. I'm joined by my co-panelists, Dr. Anita Dua and Dr. Frank Arco. I'm going to present to you some slides that have never been shown before, and this is the first time. So I'm really excited to show you some new technology, and the title of this talk is TREO, the right fit for the future of EVAR. You must know that I do perform expert consulting for TREO and help them with advancement of their aortic endograft technology. I showed some of these slides yesterday. I think I can't emphasize enough how important it is to have precise planning, because when these fenestrated cases go wrong, it's always because the plan was wrong. I do all of my measurements of branch vessels using the geometric centerline, or the centerline that's automatically generated by TREO Recon software. You can see the SMA is pictured here, the right renal, the left renal. And the manual centerline adjustment is important for measuring lengths. For ZFEN devices, we measure to the center point of the vessel, but for PMEG, I measure to the very beginning and end of the vessel. I showed this slide yesterday and how important that manual centerline adjustment actually is. You can see that in panel A, we measured from the top of the fabric edge to the top of that left renal artery and got a measurement of 34 millimeters. So we created the graft, and this was many, many years ago, in panel B. And when we went to do the procedure in panel C, you can see that that fenestration is too low. It's about 6 to 7 millimeters too low. But when you compare the geometric centerline in panel A with the Lunderquist wire in panel C, you can see that they're nothing alike. But when you manually adjust that centerline to look like the Lunderquist wire in panel C, you get a measurement of 28 millimeters, which is exactly 6 millimeters higher. So that procedure would have been perfectly planned in terms of length measurements if we had manually adjusted the centerline. You don't need to do this on every patient, especially if they have straight aortic anatomy. But when it comes to angulated aortic anatomy, it becomes very important. I also showed this slide yesterday, and this is the straightened MIP to the right and the curved planar reformats to the left. And this would suggest that those renal arteries come off at exactly the same distance, 50.1 millimeters from the fabric edge. Not so. You're going to have a long day. When you adjust that center line to look like a Lunderquist wire in the maximum point of inflection, you see that the right renal is at 36.8 and the left is at 52.6. I also showed this yesterday. This is the power of the TREO Endograft for physician-modified endografting. I'm demonstrating 2 points of fixation by holding the graft steady in place and then rotating the delivery system so that the graft collapses down. Why is that important? Well, if you look in situ, this is a 3-vessel fenestrated case where we had already cannulated the left renal artery. We've got a dry seal sheath that's 20 French in the contralateral gate. That creates 2 points of fixation so that we can then collapse the graft down and pull that right renal fenestration away from the target vessel. We can then take our wire, advance it out through the fenestration and into the renal artery. And you'll see that here. Just be patient. Somebody's going crazy here. And you can see the wire go out and then into the renal artery. We then advance the catheter across. We replace that with a Rosen wire. And then the most important thing, not to end this too early, is to unwind the graft back into place and bring that SMA fenestration directly in line with the SMA. This is a very powerful technique. It eliminates the need for constraining ties in the endograft. So we now have software-driven 3D printed templates that we're using as part of our IDE. This takes the planning, the human variability in the planning out of the equation. We use consistent sutures, consistent fenestration rings, completely reinforced fenestration rings, and reloading tools. This is about a 3-minute video, and I think it's worth showing the physician modification of the Endograft. So we're deploying the TREO. It's important to warm up the device so that it fully expands. It does have nitinol properties, and so the graft must fully expand with a temperature of over 70 degrees. In this particular case, this was a live case that we did at Viva about 3 years ago. We're using calipers to measure the positions for the fenestrations. I don't use continuous ink around the fenestration. I use little dots so that the ink doesn't bleed out. I also don't wet the graft before doing this. I use vessel loops, so essentially rubber vessel loops that are cut to the arc length size. I lay that along the outer aspect of the graft from the midline to measure my arc lengths and my distances. I then use an ophthalmic cautery to cut the fenestrations and heat seal the graft. So what this is doing is it's heating the fabric. You have to be careful because the graft can actually ignite if you hold the burning cautery onto the graft. So you heat it up, and then while it's cooling down, you slightly melt it. We then take an Amplatz gooseneck snare, and you can see that that nipple of the snare is facing toward the sheath, so that when we bring the sheath back over the graft, it allows that fenestration to collapse nicely. We then sew that gooseneck snare in a circumferential fashion for 720 degrees, so 2 times around. Again, this was 3 years ago, so now we're using the actual Tevdek suture that they use for the graft. So here's the Endograft, and let's see when this was. I think it was 2022. But here's what everybody wants to see, and that's the reloading of the graft. So now we wet down the graft, and then we use a series of Ramel tourniquets at each stent interval to cinch the graft down. So here's an umbilical tape placed, and I start down next to the sheath and I work my way back. We take this Ramel and we cinch it down to collapse the graft. You're going to see that this portion of the process is completely different now. So that's the Ramel tourniquets. We do that in 5 locations if there are 5 stents exposed. I must also say that we do deploy the TREO graft all the way down until we can see the markers at the top of the contralateral gate, so we know what orientation the graft is going to be in before we place our fenestrations. This is the tedious part of reloading this graft, is taking a moistened umbilical tape, creating an X on the nose cone, and then wrapping the device very tightly all the way back toward the tip of the sheath. And we remove the Ramel tourniquets as we pass them by. You can see that happening here. We pull those off, and then we continue to wrap. And then someone stands at the back of the device and helps to gently push the sheath forward as we're unwinding the Ramel umbilical tape and advancing the sheath. And so you'll see this completely finished here in a second, and it causes no damage whatsoever to the tip of that sheath. So that's the procedure. Now, we showed this yesterday. This is the use of 3D printed templates to actually facilitate the placement of the fenestrations. And I'll quickly go through this. But this is a very nice, instead of having to use calipers and that sort of thing, we can find the sweet spot for those fenestrations. Now, here's what I'm excited to show you, and the attorneys at TREO finally gave me permission to show you these 2 videos. This takes about 30 seconds compared to what I just showed you. This is a 3-vessel physician-modified endograft. There's a funnel that you place over the graft, and then a secondary funnel that goes over the graft. And in this particular video, we're doing the same push technique to slide the graft back into the sheath. You're probably all saying, when can I get my hands on this? Because it is quite powerful. And they've actually taken it one step further. So here's the entire graft reloaded in about 30 seconds. But now we have, I think this is going to play. Yeah. So the Terumo came up with these 3D printed, now they're injection molded devices to place on the back of the graft so that you're not pushing the sheath forward. So we slide the primary funnel over the physician-modified endograft, and then we have a secondary funnel. And they created this unique clip device that you place just in front of the sheath tip. And now with these plastic injection molding devices on the back of the delivery system, you basically just wind it back. And so you're using the same mechanism to resheath the device as you did to unsheath the device. So you can see how that's very controlled fashion. This is standardizing PMEG. Everybody talks about how everybody does it differently. This is a standardized process. And I think it's very exciting because the FDA, we showed this to the FDA and had them actually use these tools to reload the device, and they were extremely excited about it. And the last thing I'll show you is just the turning of the sheath on the back. They have another little video of that. So that's the whole device reloaded. And hopefully they'll just, yeah, so that's what they're doing from the back, is they're basically just using the same dial technique to get that reloaded. So the TREO Fit Consortium is 6 different sites across America. We met initially in 2023. All 6 sites have been approved by the FDA to do the exact same process. And in conclusion, I think physician-modified endografts are here to stay. We have a standardized process for doing this, and TREO Fit is going to be at a hospital near you soon. With that, I think I'm turning this over to Dr. Anita Ramaiah. Thank you very much.
Awesome.